Shah says, we can start.
Yeah.
Okay,
So, good morning.
Good morning,
Today
sir.
we'll have a case discussion. It's not very common. It's not given commonly in the exam, but still it's a case for discussion. And I think you'll be benefited with this discussion today. So, you'll have a presentation on a case of portal hypertension, maybe probably due to cirrhosis. We'll take the scenario that and discuss surgical part of this management. Dr. Snehashish will be presenting, and Dr. Sanjay Devakshi is a very popular teacher. Will moderate the session today, and I will also be there. Snehashish, you can share your screen and start.
Yes, sir. I have shared my screen. Can you?
Yeah, it's visible.
Okay, sir. Sir, this is 50 years. Sir, shall I start, sir?
Yes.
Okay. Good morning, sir, and good morning to all.
Good morning.
50 years male patient, resident of Goria, Kolkata, shopkeeper by profession, presented at emergency with abdominal distension for 2 months, pain abdomen for 1 month, and history of passage of blood along with vomiting few hours back.
Dr. Shah, can I just step in?
Yes.
All right. See, Snehashish, when you say history of passage of blood, it normally implies that, you're passing blood per stool. Okay. So
Yes,
what I
sir.
would suggest is what you're trying to say is vomiting of blood, isn't it?
Yes, sir. Hematemesis.
If you don't want to use the term, a medical term, hematemesis, you can say that he vomited blood, isn't it?
Okay, sir.
So don't use that term passage of blood.
Okay,
That connotation is that you're passing blood per stool. Okay.
Okay, sir.
Right.
Sir, history of present illness. Patient was apparently asymptomatic 2 months back when he observed abdominal distension, which was gradual in onset and slow in progression over 2 months. Abdominal distension is associated with dull aching pain, insidious in onset, felt all over the abdomen, which had no aggravating or relieving factors, subsided on taking oral medications. There is a history of blood with vomiting few hours back mixed with recently ingested food particles. So there is no associated history of fever, chills, or rigor. There is history of nausea for past few months with normal bowel habits. There is associated history of yellowish discoloration of urine since 1 month. There is history of anorexia and unintentional weight loss. There is no history of fresh or altered bleed per rectum, generalized body swelling, dyspnea on physical exertion. Sir, past history. Similar episode of abdominal distension 2 years back, for which he was hospitalized and was treated conservatively. Since 2 years, he has recurrent history of abdominal distension, remained asymptomatic for 6 months and started having symptoms 2 months back. There is no history of diabetes, hypertension, or thyroid disorder. There is no history of any surgical intervention in recent past. There is no history of blood or blood product transfusion in past 6 months. He takes mixed diet. There is history of alcohol consumption on regular basis over the span of 20 years. History of regular intake of pain medications and diuretics as prescribed by several physicians over past 2 years. Sleep pattern is not altered. In the family history, parents and first degree relatives had no history of any type of cancer. He has one healthy son of 18 years, no history of similar disease in his family. Sir, shall I proceed with summary of the history, sir?
Yes, please.
You can.
So this non-diabetic, normotensive male of 50 years age presented at the emergency with history of passage of blood along with vomiting few hours back, associated with history of abdominal distension with yellowish discoloration of urine for 2 months and pain abdomen, which is dull aching, non-radiating in nature for 1 month. Associated history of anorexia, unintentional weight loss, and nausea. There is no history of fresh or altered bleed per rectum or generalized body swelling. With no surgical history, he underwent several episodes of diagnostic and therapeutic abdominal paracentesis. There is history of prolonged use of pain medications and diuretics.
Snehashi, the first question I'm going to ask, when you specify unintentional weight loss, how do you quantify that, unintentional weight loss? Or massive weight loss? Do you have a qualification for this? How much of weight you would have expected the patient to have?
Yes, sir. Yes, sir. Unintentional weight loss, that is significant weight loss and insignificant weight loss, sir. The significant weight loss is 10%.
Give me a ballpark figure.
Yes, it is.
I mean, in percentages of body weight loss.
Yes, sir.
Have any idea?
Yes, sir. Yes, sir. Yes, sir. So it was 5% of 5% of body weight in past 6 months, 6 to 12 months.
10%.
10%.
10%.
Okay, sir.
Okay, so that is something that you need to know. Okay, when you're going to be asked that, if the moment you say it's unintentional weight loss, you might be asked, and you need to have the answer ready. As Professor Shah said, it is 10% of weight loss over the last 6 months. Okay, right. And in your history, you haven't said whether he had jaundice in the past.
Yes, sir.
History. Or do you think that's relevant?
So there is history of yellowish discoloration of urine for 2 months, sir.
No, but previously in the past medical history, do you think that is relevant?
Yes, sir. During the past admissions in past history, sir. So the patient was admitted for abdominal distension and several episodes of.
No, in the past. I mean, suppose Snehashi, if the patient says, "I've had jaundice, very bad jaundice,"
yes, sir.
Let's say 2 years ago, would that be significant?
Yes, sir. Yes, sir.
How would you think be significant?
So this patient didn't give any history of jaundice prior to this presentation, sir.
Sorry?
So this patient didn't give history of. Yes, sir. This patient didn't give
even any history of. That's a very important negative point, isn't it?
Yes, sir. Yes, sir. Definitely.
In the summary, when you say no history of altered bleed per rectum, generalized body swelling, I think it is a good idea to say no history of jaundice in the past, isn't it? Because what is the significance? If he had jaundice in the past, what is the significance?
Sir, if he had jaundice in the past, it means that he might have undergone any hepatic infection for which he might have.
Particularly, we are thinking of hepatitis B or hepatitis C infection, isn't it?
Yes, sir. Yes, sir. Yes, sir.
That leads to a chronic liver disease. So
yes, sir.
That is why when you say no history of fresh or altered bleed per rectum,
yes,
and
sir.
no history of generalized body swelling, I think it's very important to say that. The other important negative thing is that I noticed that in your summary, you're trying to establish a diagnosis of chronic liver disease, isn't it? So I think history of alcohol intake is a very important modality.
Yes, sir. Yes, sir. Yes, sir. Also, I have mentioned it in the personal history, sir.
No, it should come here.
It is also relevant in the summary of history. Okay, sir. I will mention it.
So it's important. I mean, look at your diagnosis. You're trying to establish a diagnosis of chronic liver disease.
Yes, sir. So he gives history of regular basis and alcohol intake for over the span of 20 years. So past 20 years.
Okay. Do you know what an alcohol unit is? Alcohol unit. A unit of alcohol. Because you need to compare, isn't it? This patient has had 3 units per day. Do you know the actual definition of alcohol unit? If you don't, I'll just tell you, it's a serving in milliliters divided by the alcohol content by volume. And the thumb rule is a can of beer is equivalent to 2 units. large glass of wine is equivalent to 3 units. These are British, it's laid down by the British Health Service. And if the patient has had a hard liquor, it's 1.4 units. Okay. So
Okay,
would
sir.
you call the patient an alcoholic?
Yes, sir. This patient is alcoholic, sir.
How do you
Past
define?
20
Yes. How do you define alcoholism?
mm,
I mean, suppose he goes in for social drinking
yes, sir.
once every month or thereabouts,
No.
versus
He
somebody.
gives
How do you
his
define?
sir. He gives history that he takes alcohol whenever he wants to. Usually
No,
3
no.
to 4
How do you define
days
alcoholism?
occasions.
When you say somebody is alcoholic, there is
Yes, sir.
some criteria that he is a chronic user of alcohol. He is dependent on that. He cannot go without it. He withdraws. His withdrawal symptoms.
Yes, sir.
So that's, as Professor Shah has said, you need to be able to define alcoholism. The moment you say somebody is an alcoholic, and I personally think that there's a journal called the Diagnostic and Statistical Manual of Mental Diseases, DSM-3, and they define alcoholism. They've got a wonderful definition. They say that you define the pathology as liver disease or functional impairment. Functional impairment both in social and or in occupation, but he can't hold down a job, or he can't, he's violent and he can't sort of have a proper social contact. Plus, whether he is tolerant or whether there's withdrawal. So, so these are the two parameters which I use. First is pathology, liver disease, or functional impairment in social surroundings and in his occupation, plus
Okay, sir.
a tolerance or a withdrawal. Just remember that. That's the DSM-3
Okay,
classification. Okay.
okay, sir.
Professor Shah, any other?
I did not like the way you start the summary, saying he is non-diabetic, normotensive. This patient came to you with bleeding. These are the two things, maybe that he was not diabetic or he has not he was normotensive. But patient coming with bleeding, they have hypertension. So it's not necessary to start this history summary with these 2 points.
Okay, sir.
Okay. These are the part of past that he was not taking any anti-diabetic drugs or he is not anti-diabetic drugs. Because these patients who come with bleeding may have hypertension. So it's not that you start history saying these 2 words.
Okay.
It's not required. You start with this 50 years gentleman presenting an emergency with history of blood vomiting associated with abdominal distension. Okay, and then in the history I've taken main part. You see, this patient who has got a background of chronic liver disease, what else you should think on the background of this history? Patient having recent onset of anorexia.
Yes, sir. Cirrhosis of liver or any other liver diseases, sir.
Cirrhosis of liver, the background is of cirrhosis of liver. He has repeated paracentesis. He has endoscopic procedures, suggestive of some variceal pathology.
Yes, sir.
So what can happen in the background of chronic liver disease?
In the background of chronic liver disease, sir, there is a replacement of hepatic parenchyma with fibrosis that causes cirrhosis of the liver, and as the disease progresses, sir, there is development of portal hypertension, sir, and there are usual presentations are after the development of portal hypertension, sir.
That is one. What else? This patient now came with a bleed. Probably
Yes,
this is acute variceal bleed.
Yes, sir. Yes, sir.
What may be the cause of bleeding in patient like this? He has got pain also.
Yes, sir. Sir, in chronic liver diseases or hepatic liver cirrhosis of liver, sir, there is coagulopathy.
One is variceal bleed. That's there.
Yes, sir.
He's asking
sir,
you about the differential diagnosis of an upper GI bleed.
Okay, sir. Okay, sir. Sir, it may be esophageal varices or varices in the stomach, sir, or it may be
yes, one broadly variceal bleed.
Chronic duodenal ulcer, sir, bleed due to chronic duodenal ulcer, or it may be due to some coagulopathy, sir, or
And you
Well,
wouldn't consider gastric ulcer?
yes, sir. Gastric and duodenal ulcer, sir.
Okay. And then you should always keep in mind the possibility of development of hepatocellular carcinoma superimposed on a background of chronic liver disease. Okay.
Yes, sir. Definitely, sir.
Presentation may be
Definitely,
just with history of anorexia and some amount of weight loss.
okay, sir.
Okay, I think we can go on to
Also, I
the.
think Professor Shah, I mean, do you think you should also define the social background of the patient out here?
Yeah. Yes. Yes.
Yes, sir.
Snehashish, how would you qualify? I mean, how do you know of any scale? It's just because I mean, during an examination, some people do get asked this.
Yes, sir. Yes, sir.
Any way of scale, or any
Sir,
scale for social?
sir, for this patient, I didn't mention that skill, sir.
Just
So,
name the scale. Do you know the scale?
sir,
Have you
Kupuswami
heard of a thing called the Kupuswami scale? I mean,
socioeconomic skill, sir.
briefly tell me what is it dependent on?
That is, sir, per capita income of the head of the family.
One.
One, then literacy status of the family members or head of the family, sir. Literacy status.
Not really the family members. So I'll tell you what the
Head
three
of the
things.
family.
It's the education of the head of the family,
Yes,
occupation of the head of the
occupation
family,
of the head of
and
the
the
family.
total per capita income of the entire family, which has been modified recently. In 2019, they've increased it. The earlier Kupuswami was 1976. Okay.
Okay, sir.
So just remember that. I mean, I think we can go ahead, Professor Shah.
Yes. Yes. Yes.
Okay.
Examine.
Examination. Okay, sir. Sir, the patient was examined in well-lit room after obtaining proper consent for examination and after explaining the proposed examination procedure in his own vernacular language, sir. He is of average build, pulse was 70 beats per minute with regular rhythms, normovolemic, no radioradial or radiofemoral delay. Blood pressure was 132 by 76 millimeter of mercury, measured in the right upper arm in supine position. Respiratory rate was 14 per minute and it was abdominal thoracic. There is no pallor. Icterus is present. There is no cyanosis. Clubbing is present, sir, of gate 3. Pedal edema is present, sir. No lymphadenopathy and neck veins are not engorged, sir. Shall I proceed, sir?
So how do you grade clubbing? You said grade 3. So how do you grade clubbing?
Sir, clubbing is of 4 grades, sir. Sir, grade 1 is fluctuation is present.
Right, fluctuation.
Grade two is
Just
increased fluctuation in at the periangle area, sir. We fix the finger with the tip of the finger is fixed and nail bed is palpated by the examining fingers, two index fingers, and if fluctuation is present.
What is the angle, Snehashish, between the nail and the finger?
Nail and it is Lovey bond angle, sir. Sir, it is normally 165 degree centigrade. It is in between the angle formed in between the line joining the nail bed and the periangle skin, sir. Yes, sir. And in case of presence of clubbing, sir, this angle is usually beyond 165 degree. Grade 1 is fluctuation is present, sir. Grade 2 is increased anteroposterior and I mean the vertical and transverse diameter, sir. Grade 3 is tissue swelling, sir. Periangle tissue swelling.
Increased curvature of the nail.
Curvature. And grade 4 is, sir, bony changes, sir. Bony changes, dystrophy.
What is the diamond?
Yes.
When sometimes some people define a diamond, what is the diamond in a clubbing?
Yes, sir. A diamond, when the two fingers are approached, sir, there is a normally there is a diamond space formed at the junction of the nail and nail bed of the two fingers, sir. But in case of clubbing, sir, there is obliteration of this diamond septate space, sir.
What is that sign called as? This is Camroth sign.
Yes, sir. Yes, Camroth sign. Yes.
It's called the Shamroth sign. Leo
Shamroth
Shamroth was a cardiologist who practiced in
Shamroth
South Africa, Johannesburg.
Shamroth sign.
So it's
Yes,
called the
sir.
Shamroth.
Shamroth sign.
Okay. Right. Icterus, where have you seen for the icterus?
Sir, icterus
Patient
is
having bleed. Patient having a bleed, having 70
Yes, sir.
pulse,
No pallor.
76 is not a very real picture, I feel.
yes, sir.
Patient having
Yes.
Pallor should have been there.
is a patient.
Yes, sir.
But
Sir,
please, there is some tachycardia. You are writing everything normal, which is
Sir.
hard to believe. Okay,
Sir,
patient having a bleed, hematemesis, that means there is good amount of blood.
yes, sir.
Okay, it's a hypothetical case, but keep in mind that patient who is feeling a
Okay.
bleed will have some amount of tachycardia. He may not be normal hypotensive at the beginning, but there should be some tachycardia.
Okay, sir.
Quite right.
Okay.
So, shall I proceed, sir?
Yes, yes.
Okay.
Yes, go ahead.
Sir, examination of the abdomen, sir, as the patient is presenting with distension of the abdomen, sir. Say on inspection, there is a generalized distension of the abdomen. There is visible superficial veins over the abdomen at the epigastrium and around the umbilicus. There is no visible scar. Umbilicus is displaced downwards to some extent, and it is everted. All quadrants are equally moving with respiration, sir. No expansile impulse on cuff. On palpation, the temperature is normal.
Even with an everted umbilicus, Snehashish, even with an everted, I know you created this thing. It's a virtual patient. With an everted, why do you think that the umbilicus is everted?
Sir, due to SIP, sir. Due to SIP.
Okay, in which case would you have expected an expansile impulse on coughing?
It has to be.
Yes, sir.
See, I mean, when you're creating a patient, so you have to be careful because you have the diagnosis in your hand, isn't it?
Okay.
So you have to be careful of staying.
And you cannot have all quadrants moving in the respiration in a patient who has got tense ascites. It is not
Yes.
appreciable. You cannot.
It's
Patient
so
having
tense,
such
it
amount of
doesn't.
distension, you cannot appreciate the respiratory movement in the abdomen. It's impossible.
Okay, sir. Sir, should I go with the palpatory findings, sir?
Yes.
Yes, yes.
Sir, on superficial palpation, sir, the temperature is normal, sir. There is no tenderness, and superficial veins, which I had earlier mentioned, sir. The flow is away from the umbilicus, both above and below the level of the umbilicus, sir. So the liver margin is smooth, non-tender, just palpable at right subcostal area, but palpable at the epigastric region, approximately 5 cm below the xiphisternum in the midlines. There is palpable spleen 4 cm below the left costal margin at the mid-clavicular line, firm in consistency, well-defined margin which moves with respiration. Per rectal examination and proctoscopy, no piles, no other abnormalities.
The liver margin is smooth. Is it firm or you haven't defined the consistency?
Yes, sir. Firm, sir. It was firm.
Okay.
In the epigastrium, you have a 5 cm being palpable. So, have you able to appreciate the surface?
Surface is coarse. I mean, sir, surface is not so smooth. Surface is, I mean,
Then
due to
you
huge
have to
ascites.
describe what you are
Yes,
finding in a
yes,
patient. You see,
yes,
you may
yes,
not always appreciate the fine granularity. The
yes,
fine
sir,
granularity may not be always appreciated on just palpation of surface. It may be difficult.
yes.
That depends on the patient scenario who is in front of you.
Okay, sir. Okay,
But,
sir.
The other thing, Snehashish, you are building up to a patient of chronic liver disease, isn't it? Isn't it?
Yes,
Your
sir.
patient is a patient of chronic liver disease, isn't it?
Yes,
So,
sir.
what is the stigmata of liver failure? What would you
I
have
think you should
said?
mention in general survey also. Yeah.
Yes.
Other stigmata apart from the dilated veins in the abdominal wall. What do you have looked for?
I mean, if you go back one slide, that's what Professor Shah is trying to say.
Okay,
Yep.
sir.
Yeah, here on.
What are the other signs of liver failure?
It said clubbing is present. Apart from
Yes,
that,
sir.
icterus is present. Apart from this, any other thing you look for in this patient?
And it's important to say that the patient, whether the patient has that or not, isn't it?
Yes, sir. Sir, any scratch marks over the body or a palmar erythema, sir?
Scratch mark is not exactly the chronic liver disease evidence. Scratch mark may present in obstructive jaundice, which may not have
Yes, sir.
a chronic liver disease.
Yes, sir.
What are the important findings? Like you said, there are dilated veins. Apart from this, what else you may have? Have you look for spider
In the
angioma?
skin,
Yes,
yes.
spider navy.
Around the neck.
Spider navy.
Yes. Any
Spider
skin
navy, sir.
changes?
Skin changes was not there,
So
sir.
one is spider navy. Any other skin changes that you've heard of?
In the palm?
In the palm?
Palmar erythema, sir.
Yes. Any
Yes.
contracture in the hand?
It was not present in this patient, sir.
So
No, but what
dependent
sort of
contracture.
expect?
Yes, sir.
What would
Yes,
you
sir.
have
Yes, sir.
expected?
Yes, sir.
A chronic
Yes,
liver
sir.
disease.
In chronic liver disease, sir. Yes, sir.
And
that
if it is a male patient,
Charcot nodules,
anything in the breast? It's a male
gynecomastia, sir.
patient.
Gynecomastia.
Anything in the breast? What have you looked for the external genitalia? All are important. You see, you
Yes,
should
sir.
know. Once
Yes,
a
yes, sir.
chronic liver disease,
Yes, sir.
you should be knowing that at least this should come in the any part of
Testis.
either in the physical examination
Yes.
of the general survey or at some part of point you have to mention that he has two stigma already in your general survey, clubbing and icterus. Apart from this, patient may have other features of CLD.
Okay, sir.
So you need to, that's an important thing to say
Yes.
negative. You know, if the patient doesn't have spider angioma, you need to mention that palmar erythema. But what is the contracture that Professor Shah was talking about? There is a name. Do you know what the name is? It's Dupuytren's contracture. You have Dupuytren's contracture. Okay.
Patient may have a parotid swelling also. Some patient may have
Parotid swelling. Yes.
Okay, sir.
Okay.
Just go to abdominal examination.
Yeah, just go to abdominal examination.
Sir, this patient actually got admitted in medicine department in Saturday from our emergency.
So the distinction is because of fluid or because of
sir, hepatosplenomegaly is also there, sir. Hepatosplenomegaly is there, sir. And also there is...
Professor Shah is pointing it out. I'll tell you why Professor Shah is pointing it out. It's obvious out here. I mean, if the umbilicus, think of the umbilicus. If it's
is not everted, I feel. You see, umbilicus is not everted.
Umbilicus is flat, sir.
Flat, yes. It can be stressed.
Flat, yes.
Yes. What you have written in percussion? Percussion, what you have written? You see, do you think this is the problem? This patient having such a tense abdomen, do you need to demonstrate shifting dullness?
No, sir.
Or will it be positive here? No.
No, sir.
Such tense aside.
Fluid thrill, yes, sir. Fluid thrill.
Yes, that's it. Don't go for shifting dullness in this patient.
Okay, sir.
There is no place for this fluid. Why the fluid get shifted? What is normal osculatory finding in the abdomen? When you put the stethoscope, when do you say normal osculatory finding?
Oh, sir,
Uh-huh.
Sorry.
Ashish,
Yes, sir.
Yes.
Sir, normal bowel
what do you
sound.
mean by
What is
normal
the
bowel sound?
normal auscultatory finding?
So bowel sounds or heard, sir. IPS or present intestinal
With such amount of 10 societies, do you think it is possible to get normal bowel sounds being audible through this fluid?
Yes, sir. It is
Very
difficult to get, sir.
Very difficult. Okay.
Yes, sir. And on
And you
auscultation,
mentioned
sir,
about a venous thumb over the epigastrium. Why would you have? You said it's a negative finding. But why would you
yes, sir.
find a venous thumb over the epigastrium? Why would you have expected?
Yes, sir. This
Which
is due
sort
to,
of
sir.
patients would you have expected?
Yes, sir. Sir, in patients with chronic liver diseases with esophageal varices and shunt, high blood flow through the shunt, sir, there is venous hum over the epigastrium. That is the auscultative findings, sir.
A venous hum arises from where? Snehashish, it is very unusual, as Professor Shah quite rightly pointed out. With such a tense societies, you don't expect a venous hum. There's a disease called a Whipple's disease, where you have extrahepatic portal vein thrombosis. And
Yes.
in that case, the veins travel up by the free margin of the falciform ligament up into the epigastrium to establish a portosystemic anastomosis. And there you get a venous hum without ascites, without marked ascites. I mean, this sort of marked ascites flattens the vein. So you wouldn't have expected a venous hum. And do you know the name of that venous hum? You mentioned it, so that's why I'm asking.
Yes, sir. Tamers.
Okay. If you don't, it's called the Cruvelia Baumgarten hum. Okay.
Yes, sir.
Just remember that.
Okay. Other system examination, normal.
Sir, the CNS, he is oriented to time, place, and person, and no other abnormality, sir. CVS examination, S1 and S2 heart, no murmur or additional sounds, sir. And chest, there is bilateral vesicular breath sound, which are diminished at the lower joints on both sides, with no added sounds, sir.
CNS examination is important because these are the patients who may have hepatic encephalopathy.
Yes,
what are the things you specifically look for? Apart from oriented time, place, and person, this is one. What are other minor neurological features?
Sir, altered mental status, confusion, lethargy,
yes.
And also irrelevant talk, sir.
Yes.
And also
anything in the palm?
Yes, a palm, sir. The palmar erythema, sir, due to hyperestrogenemia.
That is CLD. I am talking of encephalopathy features in the palm.
Tremor, sir. Tremor, sir.
Flapping tremor.
Flapping tremor.
Yes, sir.
The other term for which is asterixis. Okay.
Yes. Okay, sir. Okay, sir.
Because these are things you should mention to exclude that the patient does not have a isolated hepatic encephalopathy, because these are important in patients who have got CLD, particularly patients who are presenting with variceal bleed.
Yes, sir.
Okay, you can summarize quickly.
Okay, sir. Okay, sir. Sorry, sir, for this non-diabetic normotency. Sir, a 50 years male patient presented at emergency with acute onset of fresh bleed along with vomiting few hours back, associated with history of abdominal distension with yellowish discoloration of urine for 2 months, and pain abdomen which is dull aching in nature, non-radiating for past 1 month, associated with history of anorexia, unintentional weight loss, and nausea. There is no history of fresh or altered bleed per rectum or generalized body swelling, with no surgical history, and underwent several episodes of diagnostic and therapeutic abdominal paracentesis. There is history of prolonged use of pain medications and diuretics. Clinically, sir, the patient is icteric with clubbing and pitting edema, gross distension of the abdomen with signs of ascites, visible superficial veins at the epigastrium and around the umbilicus with away from the umbilicus flow pattern, and non-tender hepatomegaly with smooth margin, firm, mainly palpable towards epigastrium with palpable splitting and normal parectal findings.
I would have also asked, we'd been happier if you had also again mentioned no history of past history of jaundice in the past.
Yes, sir. Yes,
no
sir. And
history of blood
alcoholism.
transfusion.
Blood transfusion
And history of alcohol
alcoholism intake.
So that's an important thing
that is
which
important.
you can't afford.
Is a chronic alcoholic.
Chronic alcohol. Yes, sir.
Because the other points you'll use for defending your diagnosis. Diagnosis.
Yes. Diagnosis.
Also, if you're keen, there's Oxford Medical Education mnemonic for signs of chronic liver disease. It goes from A to J. So I would suggest you go to the internet and read it up. So that's very helpful, particularly for trying to remember.
Okay.
Because what you also need to see, in addition to gynecomastia and other signs, is testicular atrophy. Okay, so we missed,
okay, sir.
Isn't it?
Okay, sir.
Right. And change in shape of the male escutia, because it's normally in a male, the hair in the pubic area is triangular upwards. It becomes flat.
Yes, sir.
Professor Shah?
Yeah, diagnosis. I'm not very convinced with the diagnosis you put forward like this. What can be better way of presenting this patient? This 50 years, you said? 50 years gentleman?
Yes, sir. Yes, sir.
Yes. So right like that. 50 years
sorry, sir.
gentleman is a chronic alcoholic.
50 years chronic alcoholic. Sorry, sir. A 50-year-old gentleman, chronic alcoholic, presenting with
decompensated chronic liver disease.
Yes, decompensated chronic liver disease
with apardia hemorrhage, probably due to acute variceal bleed.
Acute esophageal variceal.
Yes. So that should be a proper diagnosis in this patient.
Comprehensive, yes.
Yes.
Why do you say this patient has chronic liver disease?
Sir, presentation, sir. First presentation. Sir, there is huge ascites. And
don't
also,
jump to ascites.
Okay, sir.
You see, we are asked why chronic liver disease is tell this is a gentleman who is having history of alcohol intake for such prolonged period.
Yes, sir. History of alcohol intake for long period.
Yes.
Has presented with acute onset hematemesis with
hematemesis come next. I asked chronic liver disease. So justify that he has got abdominal distension. He has got yellowish discoloration in urine. This episode happened earlier also. He required earlier paracentesis and some endoscopy procedures.
Okay.
On examination, you found this. So here comes a stigma of chronic liver disease.
Yes.
Because hematemesis can occur without chronic liver disease. Presenting with hematemesis is not the only picture for chronic liver disease.
Yes, sir. Yes.
So you need to have build up. I mean, your provisional diagnosis should be so robust that the examiner shouldn't have to ask you all this, isn't it, Ashish?
Okay, sir.
And your summary, if you had mentioned about the signs of chronic signs of stigmata of liver failure, then you would have, the examiner would have gone straight to the management, isn't it?
Yes, sir.
Right. Mr. Shah, do you want to?
Yeah. Is it a elective scenario or is it a surgical emergency?
Sir, this is not a surgical emergency, sir.
It's not a surgical emergency. Patient might die if you send him to ultrasound room.
Sir,
this is a surgical emergency, gentlemen.
Yes, sir. This is an emergency situation where the patient
seeing amount of hematemesis, you should not get misled. Just off this management slide. Take it off.
No.
Take off. We'll discuss.
We'll discuss.
Yes. Just off. Don't show this.
Okay.
So don't mistake that this is not a surgical emergency. this is a surgical emergency
Surgical
because
emergency.
whatever amount the blood is bringing out,
Yes, sir.
there will be more inside. This patient might be in shock.
Yes,
And
sir.
some
Definitely.
patient with 1 or 2 bowel hematomas may collapse.
Yes, sir.
So here the routine management will not come. Here
No, sir.
I'll be interested to ask you, if you ask how do you manage this patient, how do you start? Ask
Sir,
you how do you manage the patient, what should be your approach?
sir, the
Don't
patient.
forget the patient has come in with bleeding.
Yes, sir.
How would you approach?
Yes, sir. Sir, the patient is placed on peripheral venous access, sir, and blood transfusion if required, sir. It is
Blood
given.
transfusion straight away in emergency? How can you do that? He'll need blood, but what is the primary management for a patient who is coming with a suspected variceal bleed?
Yes, sir. Primary management would consist of, sir, medical management and intervention, sir. In medical management, sir, octreotide can be given 100 to 200 microgram bolus and 50 microgram per hour continuously. And also, if the bleeding is not controlled, sir, Sangestin Blackamore 4-way catheter can be inserted.
Blackmore is not 4-way. Blackmore is not 4-way.
Blackmore is not a 4-way.
Sangestin Blackamore catheter, sir, can be inserted.
See, Snehashish, try to think. I would have preferred that you tell me that I said it's a surgical emergency.
Yes,
so
sir.
the approach is, the first is resuscitation of the patient.
Resuscitation of the
Resuscitation,
patient.
you have to.
So resuscitation include what? Intravenous fluid, getting a peripheral IV line.
Yes, sir.
And at the same time, send this blood once you puncture this patient.
Yes,
you need not show this slide.
Okay, sir. Okay. Sorry, sir. Sorry, sir.
The first part is resuscitation, where you start an IV line. Once you start the IV line, send some basic investigation.
Institution, and after the patient is, sir, hemodynamically stable, sir, and simultaneously with the placement of peripheral access, sir.
Snehashish, Professor Shah is pointing you in the way. When you send off blood for investigations, like finish up. What have you sent off for investigation?
Sir, complete blood count.
Chronic liver disease. Who was coming with bleeding? What investigations do you send off?
Yes, sir. Sir, complete blood count, liver function test, PT-INR, blood grouping is also required, sir, and also.
Having sent it off, you start the patient on what?
Yes, you said
electrolytes.
But if you go to medical ward, you'll find that they are using some more drugs for control of variceal bleed. Octreotide is one drug, yes, I agree. But patient having hypertension, patient having a variceal bleed, what are the other pharmacological agents being used?
Yes, sir. Terlipressin, sir, can be used, sir.
Yes.
And also, sir,
vasopressin.
Vasopressin, somatostatin analogs.
That you said, octreotide. Somatostatin analog you said octreotide. Yes, but apart from this, how does a vasopressin act in variceal bleed?
Sir, it reduces the splanchnic blood flow, sir, due to vasoconstriction. And there is reduction
because it's splanchnic vasoconstriction.
Yes, sir.
Okay, it causes splanchnic vasoconstriction. And it also raises the systemic blood pressure.
The whole idea is you are trying to reduce the portal venous blood pressure, isn't it?
Portal venous pressure, yes, sir.
So initially the resuscitation, yes, agreed.
Yes, sir. Resuscitation.
And then already you have sent some basic blood
investigations.
Patient has got massive hemorrhage. He is in shock.
Yes, sir.
Yeah, given the fluid, there is some amount of response.
Okay, sir.
What should be next? There is some response, there is some elevation of blood pressure, but still not yet normotensive.
Yes, sir. Sir, we have to
maintain. This is a case of massive
Yes, sir. Yes, sir. Sir, we have to maintain the blood pressure as hypotension can further lead to increase in portal venous pressure, sir, and also can further lead to further hematemesis. So, resuscitation includes, sir, bolus IV fluid administration, and if required, sir, blood or blood product administration shall also be there, and correction of coagulopathy and correction of thrombocytopenia, if any, and also, sir, prophylactic antibiotic coverage, sir.
Patient having massive bleed. With this measure, there is some response, but BP is not normalized. There is some response. What next?
Yes, sir.
Patient is having continuing bleed. You are in a good setup. You are in a good
Sir,
setup. Then you
yes,
should
sir.
pass to the next step.
Next step, yes, sir. Sir,
What is the next step?
Sir, when the patient becomes hemodynamically stable, sir.
He is
sir,
not getting stable, I said.
Okay, sir.
He has got massive bleed. There is some
Sir,
response.
endoscopic varicose band ligation or, sir, banding can be performed.
So give a broad answer. Patient should go for endoscopic intervention. That depends on endoscopy, what he can achieve.
Yes, sir.
So the next step should be an endoscopy intervention.
Endoscopy intervention, either ligation or banding, sir.
Or
sir, sclerotherapy.
Ligation or bending
or sclerotherapy, sir.
Like with what?
Like
if there is a
what do you use for sclerotherapy?
bleed, how can you control the bleed?
Sir, control of bleeding, sir, in emergency setup, sir, is by with Sangestin Blackmore catheter.
Professor Shah asked, what is the material used for sclerotherapy? What do you use for sclerotherapy?
Ethanolamine oleate, sir, or the ethanolamine oleate.
Any glue can be used on the surface.
Yes, sir. Cyanoacrylate glue, sir.
Yes.
Yes, sir. And
also 3% polydocanol.
Polydocanol, yes, sir. Polydocanol.
Okay, it doesn't help. So you need to go to the next stage.
Endoscopic therapy has been done, but patient is still continuing to have bleed. What next?
Sir, if the endoscopy
to go by algorithm, these are the
yes,
steps. Resuscitation, endoscopic therapy, endoscopy is failing. Next is?
Sir, TIPSS can be done, sir, in emergency setup.
What is that called?
TIPSS.
TIPS. You need some time. You need some time to arrange for TIPS. It cannot be done just immediately.
Yes, sir.
What is the what do you do in the intervening time? Patient is bleeding.
The patient is continuing to bleed. So you need to do something for this patient. While you get the tips protocol, you need to get the interventional radiologist in, you need to set up the cath lab. So
yes, sir.
It will take time. So what do you do in between?
You mentioned already. Much earlier you mentioned the second tube. So you can use this same tube.
Stacking tube has how many outlets? How many?
Yes, sir.
How many balloons? How many tubes?
Balloons.
Sir,
how many balloons? How many tubes?
Two balloons, sir. One is for stomach and another is for esophagus. The stomach is approximately 250 to 300 cc of air, and the esophageal balloon is inflated with 25 to 30 cc of air, and there are two outlets.
So that's
for
two
which
tubes. Why do you?
Yes, sir. Two outlets are also there for esophageal and stomach.
There are three outlets.
Aspirations.
There are three outlets in a Sengstaken tube. It doesn't have an esophageal outlet.
One is
what do you know the name of the what is the name of the
balloon?
The 4-lumen tube is one that is called the Minnesota tube.
Minnesota.
St.
Yes,
Stachin tube has 3. Okay.
okay, sir.
Do you know of any other tubes? Do you know of a single balloon tube? Because the concept was that it's the venous flow coming in from the stomach. So you have a 500 ml tube with a single balloon, which just presses on the fundus. And that's called the Linton Nachlas tube.
Linton, yes, sir.
Okay, so you've done the tamponade,
Yes, sir.
and then you're going to get the patient ready for tips. You said, what
Sir,
do you mean by tips?
sir, if the bleeding is not controlled, sir, also, sir, tamponade can be kept for 12 hours and it can be released after for deep duration after 12 hours to prevent that esophageal mucosal necrosis, sir. And if by this time, sir, the patient will prepared for endoscopic band ligation, banding or ligation or
No.
Yeah, this patient endoscopic therapy has failed.
Oh, endoscopic
See,
therapy.
you have to go by stages. You tried medical, didn't work. You went in for endoscopy, didn't work.
Yes,
Then you've
sir.
done tamponade. After tamponade, you've already tried bone. You've already shot your bullet for the endoscopy. So then you go in for TIPS procedure.
TIPS procedure, transhepatic, transjugular intrahepatic photosystemic shunt procedure, photosystemic stent procedure, sir.
Where is the stent placed between?
Sir,
What does
the stent,
communicate?
Sir, it communicates. The stent is placed in between the one branch of sir.
If you go by the jugular, which branch is coming first?
Which branch is coming first? If you go by the jugular.
Is a communication between the right branch of portal vein and the hepatic vein.
Hepatic vein, yes.
That is the photosystemic anesthesia.
So you cannulate. I mean, the interventional radiologist cannulates the right hepatic vein, then puts in a needle from there, pushes in a bit of dye to identify the portal vein. And then, having identified the portal vein, he pulls in a Seldinger wire and the stent is pushed on top of it. So the access is from the hepatic to the portal, though the flow is from the portal to the hepatic. Okay.
Okay, sir.
Endoscopic therapy has worked. Patient has stoppage of bleeding.
Yes,
okay.
Sir.
This is a patient having such ascites. What is the subsequent management? The bleeding has stopped.
Okay, sir.
What is the management for such patient having chronic liver disease and this? In fact, how do you grade this patient depending on the liver functional status?
How do you grade this patient?
Sir, CTP grading system is there, sir, based on the parameters.
What are the parameters
sir,
take into account?
Sir, bilirubin, sir. First is bilirubin, then albumin, then presence of ascites, then presence of encephalopathy, PT, INR, PT value and INR value. All these are, assessed, and the patients are graded in 3 categories, sir. Grade A, grade B, and grade C.
Yeah. Grade A is good or grade C is good?
Which has a better prognosis, grade A or grade C?
Grade A, sir.
Yes.
Yes.
Do you any other scaling for assessing liver function apart from CTP?
Sir,
takes more objective criteria?
Yes, sir. Yes, sir. MELD scoring system, sir.
Yes.
Sir, multi-end stage liver disease scoring system. It includes, sir, sodium along with sodium is also.
That is MELD-NA.
MELD
MELD takes into bilirubin,
creatinine, bilirubin, INR, and sodium, sir.
And whether the patient has had dialysis in the past week, or or more than 24 hours continuous venous dialysis. Okay.
Okay, sir.
This patient has got tense ascites. What is the management for ascites?
Yes, sir. Sir, abdominal paracentesis can be done, which
That is
can
the
be
primary management. That is a primary management for ascites. Why does ascites occurs in CLD?
Sir, ascites occurs in CLD because of hypoalbuminemia, and there
That
is
is one factor. What else?
transudation of fluid in the peritoneal cavity.
One factor. Hypertrophy is one factor. What else? Hypertrophy is one factor.
Yes,
What
sir.
else?
What
Portal
else?
hypertension. Portal hypertension, sir.
Yes.
Yes. So what
how do
happens
you
in
address?
portal hypertension? There's a lot of fluid in the space of days, and it overruns the cisterna chyli. It actually pours out into fluid, pours out into the abdomen. What
Yes,
are the
sir.
other things? The low sodium actually stimulates both the angiotensin system and the aldosterone system, which is why you have low sodium. You need to
Hyponatremia.
have high sodium, and that is one of the reasons that you have ascites.
Yes.
So how do you
So
manage
management will
ascites?
include what? Paracentesis is not the first step, because that is not the going to address the basic pathology.
Yes, sir. Sir, ultrasonography of the abdomen can be done, which is non-invasive procedure, sir.
No, management of ascites. Ultrasound is not a management.
Oh.
How would you manage it? Your patient, I mean, the patient had a very tense ascites. So how are you
Yes,
going
sir.
to manage it? Medically, how do you manage such a patient?
Sir, diuretics can be
Patient
added.
has
Any
very
drug
high
therapy,
sodium.
I mean.
Yes, sir. Diuretics can be added, sir.
That is one diuretic. What else?
That
is on broad group.
and beta blocker,
either spironolactone or furosemide.
Furosemide or spironolactone, and beta blockers can also be added, sir.
Yes. Can also is a part of
Propanolol
treatment.
or nadolol. Yes, sir. It reduces the portal venous pressure, sir, and all. Statin.
So why do you add? Snehashish, why do you add spironolactone to furosemide?
So spironolactone
Furosemide is a much
potassium,
more powerful, much more. Yes, it's a potassium sparing, but it's
sparing diuretic. Yes, sir. And also.
Sorry. Sorry.
Sir, furosemide.
See, if you look at the kidney,
yes, sir.
So if you look at the kidney, furosemide is a loop diuretic, isn't it?
Yes, sir. Yes, sir.
So the sodium, you're trying to push out the sodium into the collecting tubules. But in the absence of any other thing, the sodium gets reabsorbed from the collecting ducts. So what works on the collecting ducts? Which diuretic works on the collecting ducts? It's a potassium sparing diuretic, thiazide, which work on those. So therefore, you have to use spironolactone with furosemide. Otherwise, the whole purpose of trying to reduce sodium is lost. Get it?
Okay, sir.
Right.
Snehashish, what are the indications for liver transplantation in patient who's got CLD? Indications for liver transplantation?
Sir, hepatic failure, sir.
Hepatic failure, what? You mean cirrhosis on the background of acute hepatic failure? Or there are some other indications?
Orthotopic liver transplant is also offered in a case of refractory ascites.
Okay, sir.
Yes.
But before reaching liver transplant, what else can you do? You've done a tips. It hasn't worked. What else can you
Yes,
do
sir. Sir,
before going for?
sir, shunt surgeries can be done, sir.
Before that, you heard of any peritoneal-venous shunts?
Peritoneal venous shunt. Yes, sir. Sir, shunt
Can you name
surgeries
me
or
can you name me a peritoneal-venous shunt?
sir, ECK fistula,
There's something called a Levine shunt,
living shunt.
isn't it?
Yeah.
Okay. So the shunt surgery also hasn't worked, so you're going in for shunt surgery. Peritoneal venous shunt. So what sort of shunt surgery would you do? Or non-selective? Very quickly, because we're running over time.
Yeah.
Yes, sir. The selective surgeries are splenorenal shunt, sir.
So what would you, what sort of surgery do you do in shunts in refractory ascites? Selective or non-selective? You actually do non-selective surgery, but you know the names of non-selective surgery?
Yes, sir. Sir, end to side portocable shunt like ECK fistula, side to side mesenteric cable shunt using a graft side to end mesenteric cable shunt or sir.
And can you do a splenorenal shunt?
Splenorenal shunt is, yes, sir. Splenorenal shunt is also can be done.
There are two splenorenal shunts. One is selective, one is non-selective.
Yes, sir. Sir,
So which is selective, which is non-selective?
Linton's and Warren's procedure are there, sir. Selective.
Yeah, Warren, is it selective or non-selective?
Warren is selective, sir.
Okay, yes. And non-selective is?
Distal.
Distal. Proximal splenoral shunt with a splenectomy.
Proximal Linton's procedure, yes, sir.
Yeah. So when you do a non-selective shunt, that what is the major problem when you have the entire portal
yes,
flow
sir.
flowing into the?
Yes, sir.
What is the risk? You're diverting the entire portal flow into the systemic circulation.
Sir, there is in most cases, sir, due to increased flow into the systemic circulation from portal circulation, there is release of
what is the
what happens to the patient?
Hepatic encephalopathy.
Yes.
Can develop.
Yes. Is higher.
Yes, sir.
Patient having massive bleed, no therapy is possible. Can you do some minimal surgery in this patient? Goes by the term called Sugiura technique. What is Sugiura procedure?
Sugiura procedure.
This is done in some desperate situation where patient has massive bleed and
yes,
endotherapy has also failed.
Okay, sir.
Don't have facility for tips. This is known as esophagogastric devascularization.
Esophagogastric
Devascularization.
Yes, sir.
Yeah. So you do a splenectomy.
You know the.
Yeah.
So basically, it's devascularization of the stomach. You leave the stomach, I do a splenectomy, remove all the blood vessels in and around the upper end of the stomach
and distal esophagus.
And distal esophagus. Before esophageal transection, this procedure was described as the Hassa procedure. Now, the Sugiura modification is that you also transect the esophagus and anastomose it again. become easier with the surplus stapler because otherwise you can't handle the submucosal variceal plexus. Okay, so that is the Seguera procedure.
It's a huge topic. You see, you should read about the scaling the liver disease, endoscopic therapy, another indication for liver transplant in patient got cirrhosis, apart from this correction of ascites or resistant bleed. Anything else? If the patient develops a ACC on the background
Hepatocellular
of
carcinoma. Yes, sir. Yes, sir.
Yeah, but tumor size should be less than 8 millimeter. Should be, I think, I don't remember the size.
Yes,
it should not be very
less
huge
than,
size.
less than 8. Yes.
Yeah.
And without any presence of extrahepatic disease.
Yeah. I think we can conclude. Sanjay, you have got good time.
Yes, yes,
Thank you
yes,
very
I
much.
think. Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thank you. Thank you, Snehashish.
Thank you, sir. Thank you,
Thank you,
sir.
sir.
Thank you, sir.
The patient, if you are present.